The knowledge base of what we do in medicine needs to have advanced to the point where you understand what a cell secretes, how cells communicate, and what growth factors are, and what an exosome is, and the different types of things. The medical industry as a whole, and in particular, I think big pharma, realized very early on that cell therapy was the way the human body works, and they had to get ahead of the narrative before the science of using your cells to help you heal got kind of out of control. All right, everyone. Thank you to this episode of the Zero Downside podcast. Just so you know, I'm going to let you know right at the beginning, I don't know that this episode can stand on its own. I think it's kind of in my head, it's a part 2, but I'm going to go through the literature on neuropathy, painful neuropathy, cardiomyopathy, diabetic neuropathy, neurogenic nerve growth, and nerve pain. I think all that are combined. And if you watch the previous episode where we talked about neuropathy of all causes, and it doesn't matter necessarily what caused it or if we ever find what caused it, the treatments for it are fraught with failure. Western medicine doesn't have a lot of solutions. There's a lot of drugs thrown at it, and there's a lot of conventional wisdom that has not elucidated to the nutritional benefits or being sound mind. There's a lot of ways to try to make you the best candidate and the healthiest person we can make you, because healthy people don't usually have a lot of neuropathy. But I think that for the most part, one of the leading causes of neuropathy is diabetes. And I think what the literature would suggest is that uncontrolled hyperglycemia, diabetes, results in damage to nerves and vessels, and the damage to nerves and vessels relates in neuropathic pain. So I spent a lot of time talking about the background of all this and kind of how we get to where we are, but I'm just trying to give people an alternative viewpoint on extra information that's been published for a really long time on what stem cells have been used for in that arena of health issues with dramatic results and really good hard science. Anyone that knows me or has been a patient, which is the primary group we're trying to reach with this, is just to give people a way of being able to rationally make good decisions on their own health care, and being able to give you the reasons why what we do works, and give you some alternative viewpoint that you're probably not going to hear if the only place you're looking for your health care information is Google, Bing, or Yahoo, or WebMD. Because they're never going to talk about cell therapy except to say that it's experimental, there's no data, it's unproven. It shows hope and promise, right? I love that. Shows hope and promise. Well, hope and promise over the last 20 years has turned into a dramatic amount of clinical results. And some of the hope and promise comes from more than 20 years ago. But eventually, hope and promise has to turn to, here's what's being done and here's what's happened. And in the scientific literature, with in vivo and in vitro studies, but mostly in vivo, we're interested in animal studies. What has been done, and do we understand the science behind why these cells would work? And the answer is yes, right? And without going too far down the science pathway, I'm going to try to distill some of the clinically relevant points for a patient. If you have a problem that seems to be unaddressed right now, or you have a family member that's suffering from an issue that it doesn't seem they have a lot of success with what the different treatments are that have been proposed, we would like to offer some alternative science to address some of those problems. So I'm going to start just a little bit of a dive, because I think this is just kind of a smattering of a little bit of different viewpoints that I think the clinical relevance of will be readily apparent when I start giving you the lay person's interpretation of what this data means. And sometimes they do a really good job of coming to the conclusion themselves, but there's a lot of take back in the science when they publish the stem cell article, because it was never intended to be a stem cell worked for this. It was intended to be what the stem cells secrete, these growth factors, this and this, that I think could represent gene therapy possibilities in the future. A lot of this study started as drug-funded research that didn't turn into a drug, or hasn't yet. And instead, the science is so significant to show that the cellular secretions themselves, maybe you should just use the cells, right? It's incredibly safe and really well published. So let's start. I think the first thing that there should be really not a lot of debate or argument over is in wound care. I think that we've been using amnion in wound care in the States since 1910. Before Marconi invented the radio, and I've said that before, if Marconi invented the radio, because he didn't, that amnion, postnatal tissue graft, the outer layer of the placenta, had been used in wound care and corneal abrasions for 100 years. So it's kind of silly that there's this much controversy over wound care at this point. And indeed, wound care literature from 2004, Diabetologica, traditional diabetes publication in Science, it's structured as a life science literature, showed that neurotrophin growth factors, NGF, pro-angiogenic and facilitated wound repair. And the NGF in this study was to treat untreated diabetic wounds, and the NGF supplementation, secondary to the stem cell graft, corrected endogenous liabilities, facilitated vascular regeneration, and suppressed the endothelial nerve growth factor and promoted reparative angiogenesis, in the fact that the wounds themselves limited the angiogenesis and the stem cell secretions promoted angiogenesis and thus the wound repair. I think the wound care literature, the healing literature for bone marrow aspirate stem cells, amniotic tissue, and growth factors from all the biologics is pretty replete and shouldn't really be questioned at this point. What about for muscle deterioration associated with chronic lower extremity ischemia, or CLI? We go through some of the CLI data on that last episode and talked about the fact that in critical limb ischemia and diabetic neuropathy, which can result in the other, that what happens is you get atrophy, degenerative muscle disease, and secondary cardiac disturbances and everything else. But muscle regeneration by bone marrow-derived myogenic progenitors. Is there any literature on that? Well, from 1998, Journal of Science. So Science and Nature are two of the more peer-reviewed, difficult journals to be published in. And because you would think that a journal titled Science any article in that might be littered with significant terms that might be difficult to understand. Maybe it's not the average layperson journal. Okay, so we're going to go through an article about muscle regeneration. So muscle regeneration by bone marrow-derived myogenic progenitor cells. And again, this is going to elucidate to the fact that a lot of the use of stem cells in the scientific literature that's been successful was only done as part of a precursor drug-funded study to eventually get a drug on the market. And that's exactly what the last sentence in this abstract is. Basically, this study shows that by taking bone marrow stem cells, they were able to regenerate damaged, within the damaged muscle, they were able to generate new muscle fibers. And so it says transplantation of genetically marked bone marrow into an immunodeficient mice revealed that marrow-derived cells migrate into the area of induced muscle degeneration. So they killed the immune systems in this mice and hurt the muscle mass. And then they took the marrow cells, administered them to the mice, and then were able, because they tagged the cells, were able to watch the cells go into the injured muscle and differentiate not only into the muscle, but actually secrete the myogenic growth factors to help the muscle heal. And they proved that. The cells migrated into the area of induced muscle degeneration. They undergo myogenic differentiation, and they participate in the regeneration of the damaged fibers. The genetically modified marrow-derived myogenic progenitors could potentially be used to target potential gene therapies for muscle tissue, providing an alternative strategy for the treatment of muscular dystrophy. Okay, so meaning that if we put these stem cells into an immunodeficient mice, meaning they've caused deterioration of secondary muscle mass, that those cells would go to the injured tissue and regenerate it. That sounds pretty important. And that was proven and published in the Journal of Science in March of 1998. And the way they proved it with the genetic markers, they literally show slides of the tissue and the damage being reversed with the amount of mitochondria and the cellular volume, where there's scant cells within the stroma and then numerous cells within the stroma. Healthy muscle, atrophic muscle. Unbelievably well put together article, and I think one of those kind of bellwether starting places for why would someone get IV therapy that has a degenerative neuromuscular disease. Well, this would be a pretty good reason, I think. The marrow-derived stem cells for neuronal differentiation, that just shows muscle. What about for nerves? What's published on the nerve side? Because peripheral neuropathy is both an angiogenic, a musculoskeletal, and a neurologic disease. This is from 2006. In vitro bone marrow-derived MSCs, they take these cells, and what they were found is that these cells express nestin. Just so you know, nestin is a really important marker protein for neural cells. It's a neurologic progenitor measurable protein. So if a cell is giving off nestin, that means you're going to see neurologic capabilities for that tissue. A specific marker for neuroprogenitors. Under differentiating conditions, MSCs display a distinct neuronal shape and express neuronal markers, NFL, which is neurofibrinolytic light protein. So it's another one of those marker proteins we're looking at, right? And class C beta turbulence. It goes through all these different markers. So I'm going to try to not bore you with too many of that. Let's get to the point. Moreover, differentiated MSCs acquire neuron-like functions characterized by cytoplasmic calcium rise in response to various neurologic activators. They demonstrate, I love it when someone says this, because I think it's stepping out on a limb to say you're doing anything for the first time. So we further demonstrated for the first time, love that clonal MSCs and their progeny, meaning these bone marrow stem cells that we grew and the cells that come from that, are competent to differentiate along the neuronal pathway, demonstrating that these bone marrow-derived stem cells share characteristics of widely multipotent stem cells unrestricted to mesenchymal differentiation pathways. What does that mean? It means that everyone that's ever said bone marrow stem cells can't do anything other than become bone is wrong. And that those bone marrow MSCs still maintain the pluripotentiality that they could facilitate and stimulate not only angiogenesis in the muscle and around the nerve, but actually neurologic healing and neuronal pathway, because that's what the cells did. And these people take the claim of being the first to demonstrate that in 2006. Sounds like it could be important when you're talking about And I love what they talk about, the classic dogma that restricts stem cell differentiation potentiality to the lineages within their tissue of origin. That's exactly what this paper is showing is not true. And I think that it's really well written. It's extremely scientific and gives a lot of the back. So if anyone out there from a scientific standpoint has a question about neuronal differentiation and the fact that this is just not possible with bone marrow cells, this paper would suggest otherwise. Implantation of human umbilical cord-derived mesenchymal stem cells as neuroprotective therapy for ischemic stroke in rats. Wait a minute. You could take umbilical cord stem cells and 2008 and treat the ischemic damage from stroke? Yep. In this present study, we demonstrate the neuroprotective effects and mechanisms of implanted human umbilical cord-derived mesenchymal stem cells in ischemic stroke. Before, during, and 1 day after in vitro, meaning in the lab, neuronal differentiation, the human MSCs produce granulocyte, stimulating factor, vasculoendothelial growth factor, glial-derived, so it goes through all the different growth factors. So they proved that these cells in the lab could produce all that. That's fascinating because we're taught that human umbilical cells aren't capable of secreting everything in the world if it's from the umbilical cord. It's just about providing health to mommy and baby, right? Maybe the umbilical cord as an organ is way more important than what a lot of people give it credit for. In an in vivo study, remember we would discuss the difference between in vitro and in vivo. So in vivo, animal study, implementation of human-derived umbilical cord mesenchymal stem cells into the damaged hemisphere of immunosuppressed ischemic stroke rats improved neuronal behavior function and reduced the infarct volume relative to the control rats. 3 weeks after implementation, most of the implanted human umbilical cord cells were present in the damaged hemisphere. Some of the cells expressed detectable levels of neuronal-specific markers. Nestin expression in the hippocampus was increased in the implanted group. Here we go. Since the human umbilical cord mesenchymal stem cells were both morphologically differentiated into neuronal cells and able to produce neurotrophic factors, but had not become functional active neuronal cells, the improvement in the neurobehavioral function and the reduction in the infarct volume might be related to the neuroprotective effect of the human umbilical cord cells rather than the formation of a new network between host neurons and the implanted MSCs. What does that mean? It means that these cells secreted and became neuronal tissue and rehabbed the stroke to increase the volume of the brain back after they had damaged it in a way that none of the control mice healed that way. That sounds pretty important for it to have been published almost 20 years ago and us still not be talking about giving MSCs IV for stroke patients, especially what about all the other things that cause stroke-like symptoms, mental clarity, loss of focus, degenerative changes? What about, I don't know, patients that have received a drug that has been associated with a significant amount of almost like encephalitis type inflammatory load, difficulty finding the word, difficulty losing math skills as an adult, earlier onset of Alzheimer's-like symptoms. It sounds like the use of IV cells in that patient, there's certainly some good scientific literature to not only suggest the pathway, all the individual growth factors, and the neurologic pathway that would provide for healing. So it's not even just theory. They did it in an in vivo study. 20 days after the induction, 77% of the inoculated MSCs demonstrated morphologic features of a neuron and expressed neuronal cell markers. Wow. We're taught that can't happen, right? Those cells just stay a stem cell. They don't differentiate into anything. Another live cell study showing about arthritis. So our goal when we treat, and they specifically call this collagen-induced arthritis because they damage the collagen fiber to cause the arthritic injury. You were able to tag those cells, put them IV, and the migration of the systemically delivered cells migrated to the inflamed joint. It's like they know what needs fixed, right? How do they do that? Well, it goes through different pathways, but the reason they do that is because that's what they were designed to do. They fix stuff. They provide the building blocks, the peptide, protein, ligand, hormonal function. In some of these cells, it's just the flat-out donation of mitochondrial volume. Like these cells can take their mitochondrial volume, which they can expand themselves as an MSC, and then donate it as these little packages of neurovesicles or endothelial growth factors or EVs, depending on what you want to call it, or exosome, because a lot of exosome is just messenger RNA, mitochondria, but it's just a packet that these stem cells are secreting to help heal the target tissue. How do they know what the target tissue is? Well, they caused the arthritic problem, and then they induced the inflammatory load, and then they gave the cells IV, not even in the joint, and the cells ended up at the area that had the biggest inflammatory load. That seems like that just giving these cells to the right people, the cells could heal what the biggest source of the inflammatory load would be, because that's how it works. And that was published in 2013. Cardiac repair. And the only reason I'm going through this, I went through this a little bit in the last one, but the reason I'm going to go through this again a little bit is just because it's in JAMA and the Journal of American Medical Association and Internal Medicine. And because this was published in the not too distant past, they did it as a review of other articles. And the background on the reason the study was published says the results of small clinical studies, right? So they're just trying to trash it right in the beginning. When you describe something as small, like clinically based, like you're just trying to show it's not a level 1 study, right? So when you do that, you've already shown your kind of bias with the way you preface what you're getting ready to say next. So everything after that kind of tainted in my mind, but only if you're a skeptic. If you're not a skeptic, when they start out that way, you're like, oh, well, so we don't want to believe this small little clinic. The results from small clinical studies suggest. That means we don't really trust it, but we're going to look at it. Now the real doctors are here. Right? JAMA's here now, right? The results of small clinical studies suggest that therapy with adult bone marrow derived stem cells reduced infarct size and improved left ventricular function and perfusion. However, the effects of bone marrow transplantation in patients with ischemic heart disease remains unclear. So all these little small studies have showed some beneficial effect, but the real doctors are here now. We're going to destroy all this data, and then we'll show you what it really means. But unexpectedly, their review of these 18 different clinical studies that they're talking about were just small little clinical samples. Out of the 18 studies that were eligible, 1,000 patients, 999 patients, with adult bone marrow stem cells that were transplanted, what happened? Well, holy moly. Like compared with the controls, BMC transplantation improved left ventricular ejection fraction. Yeah, but to what confidence level? A 95% confidence level with a statistically significant, your p-value of less than 0.001. That seems significant. It also reduced infarct size. So wait a minute. You make the left ventricular dysfunction work better, and you're going to take care of the size of the infarct and damage to my heart? Yup. P-value 0.003 with a 95% confidence value. What else could it do? Oh, it also reduced left ventricular end systolic volume, meaning when you have a heart that pumps, the dysfunction is measured by, does it empty enough or not? So if it maintains more volume, it's not working very well. So the reduced end systolic, meaning right after it pumps, a reduced volume means a healthier heart. Did it do anything to that? Yes. It's statistically significant reduced left ventricular end systolic volume. The conclusion is that available evidence suggests that BMC transplantation is associated with improvements in physiologic and anatomic parameters in patients with both acute myocardial infarction and chronic ischemic heart disease. I love this. Above and beyond conventional therapy. Therapy with BMC seems safe. These results support conducting large randomized clinical trials to look at the impact of BMC therapy versus standards of care and patient important. So at least they're saying, wow, like this is a really important problem, and we don't think that it's foundational yet, but we do think it justifies further study. So at least justifies further study. So I'm excited by the fact that at least we're doing something that justifies further study. What about the neuroprotective effect of bone marrow stem cells is not dependent on direct contact with hypoxic injured tissue, from the Journal of Experimental Neurology in 2009. I thought this was kind of foundational, and I'll go through why. Because when we talk about neuronal differentiation and healing of a neuron, we're kind of taught that can't happen. Like nerves don't heal, except when they do. Numerous studies have shown that pharmacologic neuroprotection has failed to prevent damage following stroke in clinical trials. What does that mean? It means we throw a lot of drugs at this problem, but nothing that we've given it has prevented the damage after a stroke. So there's no pharmacologic answer to post-ischemic damage. Sounds bad. The focus has shifted to new strategies to involve replacement of dead cells after the injury. Stem cell-based therapy can be an important supportive strategy in brain protection and repair. The bone-derived stem cells have been shown, I love that, have been shown to confer beneficial effects after transplantation into the animals with ischemic brain injuries. And that was from a study in 2002. And that paper, published in the Journal of Neuropathology, is titled Ischemic Rat Brain Extracts Induced Human Brain Stromal Growth Factor Production. What does that mean? I mean, they put stem cells in the brain, and it secreted all the stuff it needed to heal. Animal studies have shown that transplanted stem cells improve functional defects after a stroke. What's another paper that would show that? Well, it's from the Journal of Neuroscience in 2006, titled Adult Bone Marrow Cells Differentiate into Neurophenotypes and Improve Functional Recovery in Rats Following Traumatic Brain Injury. That was published in 2006. So we were still being taught, well, they still teach now, that bone marrow stem cells don't have a neurologic or neuronal pathway or the ability for neuronal differentiation after a stroke. Well, this paper published in 2006 says that's not true. I think that let's go through the final part of that, because I thought that was fascinating that this has been published so long ago. This study basically, so the authors concluded that the neuroprotective effects evoked shortly after ischemic injury is not dependent on cell-to-cell contacts and involves the secretion of growth factors like NGF, BFGF, and IGF. The ischemic tissue is also involved in the induction of growth factor production. So this implies in clinical practice, bone marrow stem cells could deploy beneficial effects even when applied intravenously after a stroke, even if the BMCs do not reach the infarcted area. So all the science against bone marrows after stroke or use of the stem cells IV is because it doesn't cross the blood-brain barrier. It doesn't cross the blood-brain barrier. You know what does cross the blood-brain barrier? The secretory proteins NGF, BFGF, IGF, and a host of others that reduced the infarcted area. And this study, published in 2011 in the Annals of Neuroscience, showed a pretty significant fact that we're taught isn't really possible unless you inject those cells directly into the damaged tissue. And apparently, these cells are capable of sensing the injury in the brain without being in the brain and responding appropriately by not only differentiating along a neuronal pathway, which we're taught can't happen, but by secreting the growth factors, peptides, proteins, like, again, all those secretory parts of the stem cell to help the brain heal, to repair the neuronal damage, and to lower the infarcted size of a stroke. I don't know. Sounds important. I mean, again, I'm not making any claim. I'm just a physician acting as your advocate, going through some papers that were published because the wording is pretty complicated, as you might think that anything to deal with the stem cell might be about what it secretes. And when you start going down all the different protein lines, it can get pretty complicated. But know that those growth factors are associated with neuronal recovery after a stroke. Those are secreted by a bone marrow stem cell, and they gave it IV and it made it better because it secreted that. That's the entire crust of this 30-page paper from neuroscience journals could be summarized as IV stem cells could sense what's wrong and respond appropriately. And you can see neuronal differentiation and healing, and that's published. So I didn't make that claim, but the authors of that paper seem to be making that claim. How about cell therapy for diabetic neuropathy? This is from Diabetes Metabolism Journal in 2013, and I'm just going to read their abstract because, I mean, again, it's a fairly long journal that goes through all the different pathways of therapy, all the different growth factors that the cells would go, what cell lines they expanded, and none of that's really important as unless you're going on a deep dive and trying to recreate this. But diabetic neuropathy, one of the most common disabling conditions of diabetes, which I think that we've just discussed, that neuropathy from any source can be debilitating. But in all of the diabetic literature, diabetic neuropathy, one of the most common disabling conditions of diabetes, may lead to foot ulcers, limb amputations. Despite widespread awareness of diabetic neuropathy, the only effective treatments are glucose control and pain management. Wow, when was this published? That's 2013. So even in 2013, Western medicine saying, all we have is treat the diabetes and try to manage your pain. Cut shit off, right? We're gonna start amputating your toe. We're gonna end up, when you can't heal that wound, we'll take a little bit more of your foot off. And when you can't heal that wound, we'll do a below the knee amputation. And as you get older and lose blood supply, it'll turn into you being in a wheelchair. A growing body of evidence suggests that diabetic neuropathy is characterized by a reduction of vascularity in and around peripheral nerves and deficiency in neurotropic and angiogenic factors. Yeah, I think a growing body of evidence support. I think that's kind of silly to even say it that way. It's pretty well proven, is the way they should say that, that diabetic neuropathy is characterized by a reduction in the vascularity around peripheral nerves and deficiency in the neuroprotective and angiogenic factor. Neuroprotective meaning, or neurotropic, meaning to heal a nerve and provide support for a nerve. Angiogenic factors meaning to grow new vessels and help the vessels be healthy. Previous studies have tried to induce neurotropic and angiogenic factors in the form of protein or gene therapy, but the effect was not significant. So that's the reason we're not finding out about it, because they were going to try to produce a drug with it, but the drug didn't really work. So never mind, we'll just throw this away because it didn't lead to a drug. I don't know. Does anything else happen? Recent studies have shown that bone marrow-derived stem cells or progenitor cells have favorable effects on the repair of cardiovascular disease. Since these bone marrow-derived stem cells or progenitor cells contain various angiogenic and neurotrophic factors, these cells have been attempted and used for treating experimentally diabetic neuropathy, and turns out to be effective for reversing various manifestations of experimental diabetic neuropathy. These evidences suggest that cell therapy affecting both vascular and the neural components can represent a novel therapeutic approach for the treatment of clinical diabetic neuropathy. Because the diabetic neuropathy is caused by not only the vessels, but the death of the nerve, and these cells provide support for both neuronal and the vascular component. That sounds very hopeful, and that's a review paper from a decade ago. I think that the human bone marrow-derived mesenchymal stem cells secrete brain-derived neurotropic factor and promotes neuronal survival, meaning that the BDNF secreted by bone marrow mesenchymal stem cell, in this study, we wish to determine whether MSC can secrete the growth factors which protect the cortical neurons from death by trophic factor withdrawal and nitric oxide. So they're killing these mice's brain, withdrawing the trophic factors and nitric oxide. And so as they kill the brain and induce them basically a stroke, could the MSCs that they used, bone marrow-derived stem cells, could that lower that treatment area? Wow. Well, what they found was, and reading through the way they've got every one of these growth factors is named and numbered. The addition of the MSCs, here we go. Exposure of neurons to BDNF from the bone marrow stem cell, increased activation along the AKT pathways, protected neurons from trophic factor withdrawal. These observations determine the mechanisms of neuroprotection offered by MSC-derived factors and suggest an important role for BDNF in neuroprotection. So if you want to have stable nerve growth and not lose neuronal support with chronic degenerative diseases and myelo and muscular dystrophies, it seems like MSCs might be a way to do that. And that was published in Stem Cell Research out of the Department of Neurology, Institute of Clinical Neurosciences, North Bristol, in October of 2008. Sounds important. I think this is one of my more favorite papers because it goes through all the different parts of the diabetes. So I'm going to use this last because this is about a 10-article put together that I just kind of wanted to make sure people are exposed to that information. This will be a quick one because even though it's a huge article and really, really well written from a scientific perspective, it is from Circulation Journal, which is about the most scientific of the heart journals out, and is from Circulation 2009. And it's titled Dual Angiogenic, which anyone's watched the podcast before knows angiogenesis is the growth and support of angio is vessel, like angiography is the study of the vessels of the heart. Angiogenic means to grow new vessels. So dual angiogenic and neurotrophic effects, meaning neurotrophic, nerve, trophic, growth, dual angiogenic neurotrophic effects of bone marrow-derived endothelial precursor cells on diabetic neuropathy. Wait a minute. You can use bone marrow stem cells to treat diabetic neuropathy, and it'll affect both the angiogenic and the neurotropic effect? Yes. And I love this statement because it's another one of those statements we went through a minute ago. It says, in conclusion, and let's go right to the conclusion because it's a pretty high-level study that could be difficult to extrapolate reading through all the different named growth factors. But the conclusion is pretty easy. It says, conclusion, we demonstrate, I love this, for the first time, okay, we demonstrate for the first time that bone marrow-derived EPCs could reverse various manifestations of diabetic neuropathy. These therapeutic effects were mediated by direct augmentation of neurovascularization in peripheral nerves through long-term and preferential and also so neovascularization, so new vessels, angiogenesis. The therapeutic effects were mediated by direct augmentation of neovascularization in peripheral nerves through long-term and preferential engraftment of the EPCs in the nerves, and particularly the vasonorium and their paracrine effects, meaning that vasonorium is a vessel within the nerve, paracrine effect is the effect on the direct tissue. So it didn't just increase the blood supply, it changed the health of the nerve. That's the neurotropic effect. And that was with bone marrow stem cell that we're taught can't differentiate along those pathways of neuronal support. This study, published in 2009 in the Journal of Circulation, good, hard scientific journal, should be very difficult to argue with from a zealot alternative medicine treatment standpoint. Should be hard to argue with that, and that was published in 2009. The therapeutic effect of mesenchymal stem cells for the treatment of diabetic peripheral neuropathy. Another journal article from 2017 from Experimental Neurology. What are the conclusions on this? I won't go through their model and the study. Let's just trust that if it was published in the Experimental Journal of Neurology in February of 2017, that with like 20 authors on the page, that they must have come up with something important. Well, what are the highlights of the article? According to, if you, by the person that read it, right? So MSCs reduce the number of pancreatic islet cells necessary to control blood glucose level. What does that mean? It means if you're diabetic, the islet cell from the pancreas is what determines your hyperglycemic state or the state of your blood glucose control. If you added MSCs, the number of pancreatic islet cells necessary to control the blood glucose dropped dramatically. So that sounds like almost a proposal for the treatment of diabetes. MSCs co-transplanted with pancreatic islet cells. So again, the research would be to be able to transplant pancreatic islet cells into from a donor to a host and ameliorate the diabetes, right? You could get rid of it. So, but that's been very difficult. But the MSCs, if you co-transplant them with the pancreatic islet cells, it ameliorated the diabetic neuropathy. It also, used MSCs with the pancreatic islet cells, reduced nephrotoxicity. So this is a proof of concept study. And here's the abstract. In this proof of concept study, we demonstrated using an in vivo model of diabetes, the ability of allogenic MSCs to reduce the number of pancreatic islet cells necessary to achieve glycemic control in diabetic rats. And overall, their positive effect on diabetic neuropathy with the reduction of all neuropathic signs showed after disease induction, meaning that when they reversed the diabetes, the neuropathic component didn't go away when they just did the islet cells. If they added MSCs, not only did it take less islet cells to reverse the glycemic control, meaning now they're not diabetic, but the diabetic neuropathy and all the symptoms were alleviated. So that the cutback on the pancreatic islet cell number required to control glycemia and the regression of painful neuropathy makes MSC co-transplantation a very promising tool to improve the clinical feasibility of pancreatic islet cell transplantation for the treatment of diabetes. That should be drop the mic, move on. This is important. Let's start funding some of this stem cell research without calling it heretics against Western medicine just because you want to make something better without using a bunch of drugs. All right, this is going to be kind of we're going to quote a bunch of articles here because I'm going to go through the treatment of polyneuropathy, diabetic wounds, cardiomyopathy, diabetic peripheral neuropathy. So what's published? So this is from a review paper from 2011. Mesenchymal stem cells are multipotent, self-renewing cells that can be found in almost all postnatal organs and tissues, meaning everything that comes out of mommy after the baby. So the afterbirth, the umbilical cord, mesenchymal cord blood, and the placenta. Goes through the main differentiation of that. It says, we're reviewing the potential of MSCs as new therapeutic agents in the treatment of diabetic cardiomyopathy, diabetic nephropathy, meaning your kidneys die too, right? Polyneuropathy, meaning the nerve and vessels, diabetic retinopathy, meaning you go blind, and diabetic wounds, because those are the complications of diabetes. So what's published? Really good literature showing pathways, demonstrating exactly the pathways necessary to help different things heal. We don't need to know all the name of the chemicals. We just need to know that it worked and leave the doctors to figure out why it works, right? Because that'd be my job. I would never use something I didn't understand why. Like, there has to at least be good clinical science. It has to make physiologic sense. In cardiomyopathy, what's published? So diabetes, so chronic hyperglycemia is responsible for myocardial remodeling and cardiac failure. Diabetic myocardium is characterized, so there's two enzymes, methyl-metalloprotease 2 and methyl-metalloprotease 9. Methyl-metalloprotease 2 in diabetic cardiomyopathy, methyl-metalloprotease 2 lets collagen build up. So you have a scar building up and it doesn't work. Methyl-metalloprotease 9 should kind of remodel that and help vascular supply. So you have two, it's kind of a push-me, pull-me effect of methyl-metalloprotease. So MMP is not all bad. Some of it's good, but it regulates the back and forth. You got to get a little bit of inflammation to get healing, but you don't want to get overgrowth of one. What happens in diabetes, you get all this big MMP2 and the deactivation of MMP9. So what would happen is you get myocardial dysfunction because of the collagen accumulation and the activity of the apoptosis of the MMP9. So it kills all the cells and won't let it regrow. So that's why the poor myocardial refusion. Anyway, MSCs can induce myogenesis and angiogenesis by releasing different angiogenic, mitogenic, and anthropotic, meaning against the death of a cell, factors, including vascular endothelial growth factor, insulin-like growth factor, AM with andromedin, hepatic growth factor. It goes through all the different growth factors. Then these were demonstrated in a rat model. So wait a minute. So the diabetic cardiomyopathy in a double-blind, placebo-controlled study showed that IV autologous MSC transplantation increased left ventricular ejection fraction, reduced episodes of ventricular tachycardia, and led to reverse modeling in post-infarction patients and stroke. That sounds pretty important. So we could use MSCs to help heal your heart, turn back the hands of time on damage, make the methyl-metalloprotease things work better, get rid of a lot of the collagen, and decrease the amount that MMP9 is killing the cells around the heart after an infarction. That was published, and there's the secondary study published on that. And if you want to look that up, is from the Experimental Clinical Endocrinology of Diabetes from 2008, showing that bone marrow mesenchymal cells induce angiogenesis and attenuate the remodeling of diabetic cardiomyopathy, published in 2008. So bone marrow stem cells helped the heart heal and reverse some of the effects. Sounds incredible use of cells, right? What about diabetic nephropathy, I mean the death of a kidney? MSC administration can prevent and treat diabetic nephropathy, which is a combination of diabetes mellitus, is defined as the progressive kidney disease caused by the angiopathy, meaning that you don't have good blood supply to the kidneys, so the kidneys die, right? So and the capillaries of the glomeruli of the kidney. MSCs have been used for the treatment of diabetic nephropathy in non-obese, diabetic, and severely compromised immunodeficiency patients. MSCs indicate and injected into the MSC engraft, they engraft in the damaged kidneys, differentiate into renal cells, regulate the immune response, resulting in the efficient treatment of diabetic nephropathy. That was published in Systemic Administration, meaning given through the IV, of multipotential mesenchymal stem cells, reversed hyperglycemia, and prevents nephropathy in type 1 diabetic mice. The Biologic Blood Marrow Transplant Journal of 2008. Had no idea. What about, also multipotential stromal cells from human bone marrow repair pancreatic island cells and renal glomeruli in diabetic neuropathy. That was published in National Academy of Science 2006. Okay, so now we're going to help heal the damage to nerves, vessels, and kidneys, and heart. What about diabetic polyneuropathy, the most common complication of diabetes? It's associated with damage to the death of nerve fibers. Goes through the Ys, damage to the angiogenic cytokines, growth factors. It was shown in diabetic rats, the MSCs, because of their ability to secrete BFGF and VEGF, could be used as a new and effective therapeutic agent in the treatment of diabetic peripheral neuropathy. That was published in Circulation Journal. Remember, I like that one, from 2004. Local delivery of marrow-derived stem cells augments collateral perfusion, so it brought back blood supply. Transplantation of bone marrow-derived stem cells improves diabetic polyneuropathy in rats, Journal of Diabetes, 2008. So we've been doing animal studies to show that MSCs decreases diabetic peripheral neuropathy by both a neurologic and an angiogenic pathway for 20 years. I think we'll stop. I mean, at this point, the goal of the literature review on some of this, treatment of bone marrow-derived stromal cells accelerates wound healing in diabetic rats. Like, there's some of these papers I'll put together is just to make sure that patients know that this stuff isn't made up as you go, right? Like the reason it's easy to be, you know how difficult it would be to be passionate about something that didn't work, right? And if it didn't work, I would have gone on to something else. The reason that we found a lot of the science on the stem cell side of this and our use of bone marrow cells and all the angiogenic proteins and all of the postnatal tissue graft, and the reason for the development of a clinic in another country to use culturally expanded human umbilical cord cells IV is because there's so many problems that I have to address that there wasn't a great answer for. If we still didn't have a good answer for it, I will move on to the next thing. The goal is to find solutions to the unanswered problems. If we already had all the answers, we wouldn't be still doing all this. We obviously don't have all the answers in Western medicine that we need. There are a lot of problems that we just don't have solutions for. I hope that going through the literature, you found out that maybe it's not that the human body doesn't have solutions for it. It's just there's not a drug or coded, approved therapy that follows along the narrative of the people that reimburse for those that has been generally accepted. But certainly it's not about, has it been scientifically studied? And it would seem to be that the scientific evidence is way on the side of what we're talking about for people. Our goal is always just to help you be the best you. For every cancer, there's people that have survived it. And I think that when you think of the fact that everyone in every room at all times, they all have some form of cancer, but the body does a really good job of destroying most of it because that's what it's meant to do. The abnormal tissue is the outlier. The normal healthy tissue rules the day. Our goal is to help you be a healthier you, and you can fight back. That's what the cells are doing. They're helping you fight back. Why do I know that? Because that's why they're in you in the first place, and that's their main function as you get older. So we're just augmenting that ability of those cells to do what they would like to be able to do. Hopefully that makes sense. I don't think the science behind the way a stem cell works is that complicated unless you start trying to track down every little individual growth factor and how and what its end target organ is. And then it can get extremely complicated. And I think that that's because it's a really complicated pathway. It doesn't mean it has to be a complicated to understand it. If you want to know exactly how it works, it'd be pretty difficult, and that's why these are studied. But if you just want to know, does it work or not, I think the answers to that are pretty robust in the literature at this point. Anyway, thank you again for your time and attention. If you made it to this point, it means that you or someone in your family has diabetic neuropathy, diabetic cardiomyopathy, heart disease, some kind of a pulmonary dysfunction, or renal failure, because this is pretty well studied that these cells can make a difference in those problems. Again, not me making that claim, just reading through the literature and showing you what it shows. Thank you so much for your time and attention. I hope that you're able to perceive that the passion behind this is because of our belief in the treatment and certainly the patient results that we've seen. The science of what we do continues to develop and move forward because patients are driving it, not drug company, not pharma, not insurance dollars. It's results, and it's very results driven, and it's very patient driven. And I want to thank you again. Genuinely care and appreciate the trust you place on us to take care of you and to kind of navigate the storm on your behalf. Thank you so much.